Parkinson's disease and Parkinsonism. Parkinson's disease patient with shaking hand. Parkinson's disease, PD, is called a movement disorder because of the tremors, slowing, and stiffening movements it can cause, and these are the most obvious symptoms of the disease. However, Parkinson's affects many systems in the body. Its symptoms are different from person to person and usually develop slowly over time. The prevalence of Parkinson's disease, PD, has doubled in the 25 years to 2022. The number of disability-adjusted life years caused by PD increased by 81% from 2000 to 2019. There was an increase of more than 100% in deaths caused by PD in the same period. Source: WHO. Infographic with the following information: 8.5 million people with PD globally in 2019, 5.8 million disability-adjusted life years caused by PD in 2019, 329,000 deaths caused by PD in 2019, greater than 100% increase in deaths caused by PD from 2000 to 2019, 0.5 to 1% prevalence among 65 to 69-year-olds, 1 to 3% prevalence among those greater than or equal to 80 years, greater than 30% expected increase in prevalence and incidence by 2030, 4% diagnosed before age 50, 1.5x men more likely to have PD than women, 0.03 per 100,000 neurologists in low-income countries, 4.75 per 100,000 neurologists in high-income countries. Sources: Source: WHO. Source: Parkinson's Foundation, Coley et al. 5 ms. Parkinson's disease and movement disorders touch on all aspects of the 5 ms framework. Impaired mobility, cognitive decline, and complex interactions with medications are key features of Parkinsonism. Patients experience a huge change to their quality of life, which requires personalized care that takes into account the biopsychosocial context. Learning outcomes. On successful completion of this module, you will be able to formulate differential diagnoses for symptoms of Parkinson's disease and Parkinsonism. Interpret relevant investigation to differentiate between idiopathic Parkinson's disease, other causes of Parkinsonism, and other movement disorders. Select appropriate initial pharmacological therapy for idiopathic Parkinson's disease and counsel patients on potential side effects. Educate patients, their caregivers, and members of the interprofessional team on common causes of deteriorating symptoms of Parkinsonism. Implement strategies to prevent deterioration of Parkinsonism symptoms in healthcare settings. Version 2.10.6.
Yeah.
Differential diagnosis for Parkinson's disease. Robert, aged 76, feels that he has slowed down over the past 6 months and has become much less active because he feels unsteady while walking. Select each tab to review Robert's patient record. Patient. Presenting complaint. Medical history. Examination results. Patient. Name, Robert. Age, 76. Robert. Presenting complaint. Robert reports a change in his sleep over the past 1 year. He reports vivid dreams and nightmares. He reports feeling low mood but no suicidal ideation. Robert reports having 3 falls in the past 6 months. Arthur, who acts as a carer for Robert since his husband Philip died, confirms that Robert now moves around during his sleep, kicking out his arms and legs, and sometimes seems to be acting out his dreams, REM sleep disorder. Medical history. Robert reports constipation for the past 2 years. Examination results. A mini-cog cognitive assessment is performed yielding a score of 5 out of 5. What is the differential diagnosis for Robert? Show differential diagnosis. Parkinson's disease, PD, also known as idiopathic Parkinson's disease, IPD. Drug-induced Parkinsonism, caused by dopamine antagonists. Essential tremor, tremor worse on movement, improves with alcohol consumption, often runs in families. Multisystem atrophy. Progressive supranuclear palsy. Wilson's disease, rare greater than 50 years. Traumatic brain injury. Vascular Parkinsonism. Corticobasal degeneration. Match the description to the correct label. Progressive neurodegenerative disease caused by the dysfunction of the nerve cells in the brain that produce dopamine. Clinical syndrome, which may have neurodegenerative and non-neurodegenerative causes. Submit. Correct. Incorrect. Parkinson's disease, also called idiopathic Parkinson's disease, is a chronic, progressive disorder caused by degenerative loss of dopaminergic neurons in the brain. PD is characterized clinically by asymmetric Parkinsonism and dramatic, sustained benefit from dopaminergic therapy. Parkinsonism is a clinical syndrome that can manifest as a combination of bradykinesia, slowness of movement, accompanied by either rest tremor, rigidity, or postural instability. The prevalent type of Parkinsonism is known as Parkinson disease, PD. Parkinsonism is sometimes known as atypical Parkinson's or Parkinson's plus. Source, Cho, Kelvin. What percentage of Parkinsonism do you think is attributable to idiopathic Parkinson's disease? Drag the slider to the correct percentage. 0%. 100%. Correct answer, 80%. Submit. Correct. Incorrect. Parkinson's disease represents about 80% of all diagnosed cases of Parkinsonism. Version 2.10.6.
Parkinson's is the second most common neurodegenerative disease after Alzheimer's. The most visible features of this disease are a slowness of movement, muscle rigidity, and tremors at rest. There are also many, often debilitating non-motor symptoms, some of which may present before the motor problems. Parkinson's affects many areas of the nervous system and different types of neurons. However, much focus has been placed on neurons in brain regions associated with the overt motor symptoms, notably a region of the midbrain called the substantia nigra pars compacta. This region forms part of a major pathway in the brain that's critical for facilitating movement. In Parkinson's, dopaminergic neurons in the substantia nigra gradually die, leading to the malfunction of this pathway and the characteristic motor problems. Drugs that replace or mimic dopamine are often used to treat these motor deficits, but they grow less effective over time. Deep brain stimulation may also be used to treat symptoms. However, no current treatment slows the neurodegeneration. A distinctive pathology in most cases of Parkinson's is clumps of misfolded proteins within neurons. Lewy bodies are the most common type. A characteristic component of these is a misfolded protein called alpha-synuclein. These molecules can form small repeated units called oligomers, or longer fibrils. Mounting evidence indicates that these are toxic to neurons and play a key role in driving Parkinson's. Unwanted proteins are normally cleared by the cell's different types of protein-degrading machinery. Some evidence points to these systems being overwhelmed by misfolded alpha-synuclein, and this might be a key factor in what kills the neurons. Parkinson's has also been linked to problems with mitochondria. Mitochondria provide cells with the energy to perform vital functions. They're highly dynamic and can fuse together or break up into smaller versions in response to a cell's energy demands. They can also be transported to areas of a cell that need them the most. However, in Parkinson's, these processes can be impaired, and mitochondria are unable to sustain proper neuronal function. As they become old or damaged, mitochondria are removed and replaced. Again, this recycling is thought to be disrupted in Parkinson's, leading to the accumulation of damaged or worn-out mitochondria. Another idea is that the cells called glia surrounding neurons may play a role in Parkinson's. As dopamine neurons are lost, one particular type of glial cell, called microglia, is thought to take up the resulting cellular debris, triggering an immune response. Once activated, they release inflammatory cytokines, which activate neighboring microglia and another type of glial cell called astrocytes. Chemicals released by activated microglia and astrocytes have been shown to injure neurons. It remains unclear which mechanisms drive the disease process in Parkinson's. What is clear is that with time, more areas of the nervous system develop pathology. And one emerging idea is that this happens through the transmission of misfolded alpha-synuclein. While the multifactorial nature of Parkinson's disease progression might make it hard to fully understand, it does provide a number of potential therapeutic targets for slowing or even halting the neurodegeneration. For example, enhancing the clearance of abnormal proteins and blocking their transmission, improving the function of mitochondria, and targeting the neuroinflammation are all currently active areas of research.
Diagnosing idiopathic Parkinson's disease. Investigations and diagnosis. IPD is a clinical diagnosis made by identifying the typical clinical features. Are there any of Robert's symptoms that suggest IPD over any other diagnosis? Show symptoms. Robert has resting tremor with pill-rolling appearance indicative of IPD. He has postural and gait instability. Feeling low is a non-motor symptom of IPD. REM sleep disorder is a non-motor symptom of IPD. Clinical examination. The Movement Disorder Society's Unified Parkinson's Disease Rating Scale, MDS-UPDRS, was developed to evaluate various aspects of Parkinson's disease. It comprises a questionnaire that assesses the non-motor and motor experiences of daily living and motor complications, as well as a number of motor evaluation tests. The scale is used in research to characterize the extent and burden of disease across various populations. It can also be used in a clinical setting. Select the card to view the findings from his clinical exam. Upon clinical examination, the following are found which are suggestive of PD. Small handwriting, micrographia. Reduced facial expressions. Increased sebum production on the face resulting in oily skin. Hypophonia. Reduced sense of smell. Role of imaging. Many of the motor and non-motor symptoms of PD are the result of depletion of the neurotransmitter dopamine in the brain. Dopamine decreases due to the death or breakdown of dopamine-producing neurons. A specific imaging technique, dopamine transporter single photon emission computed tomography, DAT SPECT, can be used to help differentiate IPD from other movement disorders by assessing the function of the dopamine active transporter. In this functional imaging technique, an intravenous radioactive tracer is administered into the body. The imaging reflects dopamine uptake by surviving presynaptic dopaminergic neurons in the striate bodies of the basal ganglia. Reduced uptake of the radioactive tracer in the basal ganglia may indicate IPD. Source: Fernandez. Move the slider to compare a DAT SPECT of a person without Parkinson's disease and with Parkinson's disease. MOV DAT SPECT of a person without Parkinson's disease, DAT SPECT of a person with Parkinson's disease. Robert had a DAT SPECT scan, which showed evidence of reduced uptake in the basal ganglia. Idiopathic Parkinson's disease was diagnosed. We will return to Robert's case later. Robert. For more information about the MDS-UPDRS, access the following resources. MDS Unified Parkinson's Disease Rating Scale, MDS-UPDRS. MDS-UPDRS, the MDS-sponsored revision of the Unified Parkinson's Disease Rating Scale. If needed, refresh your knowledge of examination findings in common neurological conditions. Version 2.10.6. Meet Eliza. Eliza, 85, presents to her general practitioner, GP, reporting a change in her walking. Select each tab to review Eliza's patient record. Patient. Medical history. Current medication. Examination results. Patient. Name, Eliza. Age, 85. Eliza. Medical history. Schizophrenia. Chronic obstructive pulmonary disease, COPD. Hypertension. Smoking. Current medication. Haloperidol 5 mg twice daily. Tiotropium bromide inhaler 18 micrograms once daily. Lercanidipine 10 mg once daily. Examination results. Reduced facial expressions. A resting tremor is evident in both hands, but worst in the left hand. Increased tone in the left upper limb. Gait examination reveals a slow and shuffling gait with reduced arm swing and on the left arm. What do you think is the most likely diagnosis for Eliza? Show diagnosis. Eliza's symptoms are the result of drug-induced Parkinsonism. The side effects of some medications resemble the physical symptoms of Parkinson's disease. When medications are the cause of symptoms rather than neurodegeneration, this is referred to as drug-induced Parkinsonism. The medications most likely to induce this effect usually belong to the following categories: anti-nausea, neuroleptic, antipsychotic. The reason for this is these medications are dopamine antagonists. They act on blocking the dopamine receptors in nerve cells, which results in reducing dopamine levels. Source: Peckham. Eliza's case will be continued later in this week's learning, where you will explore her treatment options. Atypical Parkinsonism. Drug-induced Parkinsonism is one form of atypical Parkinsonism. Atypical Parkinsonism is not neurodegenerative and usually has an identifiable cause, such as drug side effects, exposure to environmental toxins, trauma, multiple strokes, other nervous system disorders, infection, or illness. Type of Parkinsonism. Common symptoms: progressive supranuclear palsy, PSP. Problems with eye movement, balance, mobility, speech, and swallowing. Multiple system atrophy, MSA. Stiffness and slowness of movement, early stages, unsteadiness, falls, bladder problems, and dizziness. Vascular Parkinsonism. Problems with memory, sleep, mood, and movement. Corticobasal degeneration. Clumsy hand, muscle stiffness, tremors, dystonia, numbness, alien limb. Chronic traumatic encephalopathy. Early stages, short-term memory loss, changes in mood, increasing confusion and disorientation, difficulty thinking or making decisions. Later stages, dysarthria, significant memory problems, tremor, slow movement, muscle stiffness, dysphagia, rare. Drug-induced Parkinsonism. Similar to IPD, but symptoms do not progress over time. Source: Parkinson's UK, NHS. It is important during consultations to recognize clinical features that suggest a diagnosis other than Parkinson's disease. Select the item to see features of atypical Parkinsonism. Features of atypical Parkinsonism. Early onset of postural instability and falls. Axial rigidity, e.g., stiff neck, more than appendicular rigidity. Early onset of dementia. Supranuclear gaze palsy. Unusual movements besides tremor. Limb dystonia. Myoclonus. Limb levitation. Alien limb syndrome. Severe autonomic dysfunction. Psychotic symptoms, prior to receiving levodopa or dopaminergic medication. Poor response to typical dosages of levodopa. Source: Fernandez. Graphic showing obstructed blood supply in blood vessel. Where possible, all efforts should be made to make an accurate diagnosis of the cause of Parkinsonism, as this optimizes the care pathway and saves time. While vascular Parkinsonism has similar symptoms to Parkinson's disease, The underlying mechanism is not neurodegeneration, but rather cerebrovascular disease. Vascular Parkinsonism is caused by small strokes, which damage the blood vessels in the brain and affect blood supply. Consequently, vascular Parkinsonism patients do not respond to medications used for Parkinson's disease such as levodopa. Source: DZN. However, it may take time to make a diagnosis as a number of causes need to be excluded. In some cases, it may not always be possible to make a precise diagnosis of atypical Parkinsonism disorders. This is not typically a problem as the treatment is generally the same for all of them. Levodopa, if it shows efficacy and is well tolerated. Inefficacy of levodopa can help point to a diagnosis, e.g., vascular Parkinsonism. Neuroimaging with CT or MRI can be helpful to assess for evidence of vascular Parkinsonism. Other treatments should be offered on a symptomatic basis, e.g., medications and therapies for cognitive impairment, mood disorders, autonomic dysfunction, mobility issues, speech issues, swallowing issues, and so on. Source: Spindler. Levodopa. The following website provides useful resources concerning Parkinson's disease. Understanding Parkinson's, Parkinson's Ireland. Version 2.10.6. Summary for Parkinson's disease and Parkinsonism. Key learning points. You have completed this section. Review each key learning point before you progress. Idiopathic Parkinson's disease, IPD, is a progressive neurodegenerative disease caused by the dysfunction of the nerve cells in the brain that produce dopamine. Parkinsonism is a clinical syndrome, which may have neurodegenerative and non-neurodegenerative causes. A PD diagnosis requires bradykinesia plus at least one of tremor, rigidity, or postural instability. The Movement Disorder Society's Unified Parkinson's Disease Rating Scale, MDS-UPDRS, can be used to evaluate various aspects of Parkinson's disease. Many of the motor and non-motor symptoms of PD are the result of depletion of the chemical messenger dopamine in the brain. Dopamine decreases due to the death or breakdown of dopamine-producing neurons. A specific imaging technique, dopamine transporter single photon emission computed tomography, DAT SPECT, can be used to help differentiate IPD from other movement disorders by assessing the function of the dopamine active transporter. When medications are the cause of symptoms rather than neurodegeneration, this is referred to as drug-induced Parkinsonism. The medications most likely to induce this effect are anti-nausea drugs or neuroleptic, antipsychotic drugs. Patients with PD often experience the change in voice volume, speaking lower than before and with abnormal intensity. Dedicated speech therapy such as the Lee Silverman Voice Therapy, LSVT, program has been shown to be effective. Version 2.10.6. Management of Parkinsonism. Robert was diagnosed with idiopathic Parkinson's disease, IDP, following a clinical assessment and a DAT SPECT scan. What do you think the treatment options for Robert are? Show options. Dopamine replacement therapy is the mainstay of treatment for idiopathic Parkinson's disease, IPD. Symptoms of Parkinson's disease can be significantly ameliorated through medical treatment. However, there is no cure, and progression of the disease cannot be slowed. Monitoring progression of the disease and the effect of pharmacological agents on progression is difficult with Parkinson's disease because its effect is idiosyncratic with a wide spectrum of symptoms, long time course, and lack of definitive markers. Source: Fernandez. There are a number of pharmacological therapies that can be used in managing patients with IDP. When treatment starts depends on how the symptoms affect the patient and can be agreed with the patient. It is generally considered necessary to start treatment when gait problems commence due to the risk of falls and serious injury. Select each category to learn more about pharmacological treatment. Levodopa. Levodopa is the gold standard treatment of symptoms of Parkinson's disease. Levodopa is combined in various concentrations with another compound, carbidopa, to improve its efficacy and reduce side effects such as nausea. Carbidopa alone has no benefit. Levodopa is particularly effective for helping people who have bradykinesia, slowness of movement. It can also help with tremor and rigidity, especially when they occur later on in the disease. However, it is not likely to improve problems with standing, balance, and coordination. A pitfall with levodopa is the development of dyskinesias. These occur in 80% of patients after 5 to 10 years of treatment. However, most patients prefer dyskinesias to rigidity and bradykinesia. Adjusting medication may help control troublesome dyskinesias. Some other common side effects are nausea, sleepiness, dizziness, and headache, confusion, hallucinations, delusions, agitation, and psychosis. Side effects can usually be avoided or minimized by starting with a low dose and increasing gradually. Dopamine agonists. Dopamine agonists work by directly stimulating dopamine receptors in the brain. They are effective for controlling the symptoms of Parkinson's disease. They may be used alone as an initial treatment for people with early Parkinson's disease, especially those less than 65 years. Dopamine agonists may postpone the need for levodopa for this cohort, which has been linked to delayed onset of motor complications and dyskinesia. While dopamine agonists may control symptoms in the early stages of the disease, most people with worsening symptoms require levodopa within a few years. Initial symptom control is usually less effective than with levodopa. In addition, there are usually more side effects, including sedation, swelling of the legs, visual hallucinations, and impulse control disorders such as compulsive gambling, eating, or shopping. Patients and clinicians should reach a shared decision about treatment after discussion of the advantages and disadvantages of either medication. MAOB inhibitors. MAOB inhibitors work by blocking the effect of enzymes that inactivate dopamine and allow dopamine to remain in the brain for longer before being broken down. They can be taken alone or in combination with levodopa or other anti-Parkinsonism drugs. The benefit of this medication is limited, with some patients showing no improvement. Side effects of MAOB inhibitors can include nausea, headache, and difficulty falling asleep. Confusion can occur in older adults treated with selegiline, which may preclude its use in this group. Combining antidepressants and MAOB inhibitors can, rarely, lead to development of serotonin syndrome. Eating foods with high tyramine can trigger an adverse hypertensive reaction, with accompanying morbidity. Foods with high tyramine include types of fish and meat, e.g., sausage, turkey, liver, salami, certain fruits, e.g., overripe fruits, avocados, bananas, raisins, figs, cheeses, alcohol, and fava, broad beans. COMT inhibitors. The catechol-O-methyltransferase, COMT, inhibitors tolcapone and entacapone are used to prolong and optimize the efficacy of levodopa. This treatment option is usually reserved for patients with motor fluctuations who have wearing-off periods at the end of their dose of levodopa. They are only used in combination with levodopa. The most common side effects of these drugs are dyskinesia, hallucinations, confusion, nausea, diarrhea, orange discoloration of urine, and low blood pressure upon standing. Tolcapone may lead to an increase in liver enzymes. Regular monitoring is recommended during the first year of treatment. NDMA antagonists. Amantadine, an antiviral drug originally developed as an influenza vaccine, has been found to improve mild symptoms, tremor, akinesia, rigidity, in people with Parkinson's disease. Amantadine can be used in combination with levodopa to help reduce dyskinesia in patients with advanced Parkinson's disease. The benefit of this medication is temporary for some patients. Side effects include visual hallucinations and confusion, libido reticularis, blotchy, purple-colored areas of skin usually found on the wrists and legs, and swelling of the ankles. Anticholinergics. Anticholinergic medication can help reduce symptoms of tremor in people less than 70 who do not have significant akinesia or walking problems. These medications can be used alone. For patients with more advanced Parkinsonism, who have a persistent tremor, they may be used in combination with levodopa or dopamine agonists. Common side effects of anticholinergics are dry mouth, blurred vision, constipation, nausea, difficulty voiding the bladder, impaired sweating, and rapid heart rate. Older adults or those with cognitive impairment issues may experience difficulty with memory, confusion, and hallucinations. Category: Medications. Dopamine. Levodopa. Carbidopa prevents conversion of levodopa to dopamine outside of the brain. Apomorphine. Dopamine agonists. Rotigotine. Ropinirole. Pramixpol. MAOB inhibitors. Razegeline. Selegiline. NMDA antagonist. Amantadine. COMT inhibitors. Entacapone. Anticholinergics. Trihexyphenidyl. Benztropine. Orphenadrine. Procyclidine. Biparidine. Source: Fernandez, Tarzi. Parkinson's patient with gel cartridge surgically attached. Administration. Most drugs are administered orally, ranging from once a day to 2 to 3 times daily. There are also options for administration using dispersible agents, e.g., levodopa brand Matapar, and transdermal patches, e.g., rotigotine. In recent years, infusion pump has become an option for administration of therapy. In January 2015, the U.S. Food and Drug Administration, FDA, approved a system that continuously delivers levodopa-carbidopa in a 4:1 ratio in gel suspension for 16 hours directly into the small intestine, minimizing motor fluctuations. The patient changes the cartridge daily and turns it off at bedtime. Robert was treated with an oral levodopa-carbidopa regimen. This regimen was selected in order to optimize his functional improvement in response to therapy. Dopamine antagonist was an alternative option that was considered before deciding on the levodopa-carbidopa regimen. Robert expressed his preference for levodopa-carbidopa due in part to its greater potential to help with his bradykinesia. Pills dispenser tray. Version 2.10.6. Other management options. Eliza was diagnosed with drug-induced Parkinsonism. She was on a number of medications. Haloperidol 5 mg twice daily. Tiotropium bromide inhaler 18 micrograms once daily. Lercanidipine 10 mg once daily. Is pharmacotherapy treatment appropriate for her? Show treatment option. Drug-induced Parkinsonism is less likely to respond to dopamine therapy than is idiopathic Parkinson's disease. The mainstay of therapy for drug-induced Parkinsonism is slow weaning of the dopamine antagonist if possible. In Eliza's case, this would involve tapering her off her haloperidol regimen, which she subscribes to in order to manage her schizophrenia. Along with weaning Eliza off haloperidol, what other actions should be taken, do you think? Select each card to see Eliza's management plan. Eliza is treated with slow weaning of her antipsychotic therapy, physical therapy, occupational therapy, speech and language therapy. In consultation with her psychiatrist, she was switched to quetiapine, which has less extrapyramidal side effects. Routine follow-up was scheduled. Following gait and balance training, provision of assistive and adaptive devices were provided. This, along with the medication changes in therapy, led to her symptoms improving. Carlos. Meet Carlos. Carlos is 76. He was diagnosed with Parkinson's disease 4 years ago. He gets some benefit from medication but still suffers from dyskinesia. He has significant off periods, where the medication does not work so well and his symptoms return. Otherwise, he is quite healthy and is supported by a large family unit. Are there any other treatments that could be beneficial for Carlos? Select the item to see what could be done for Carlos. Option for Carlos. Carlos may be considered for deep brain stimulation. Illustration of patient with device for deep brain stimulation implanted. Continue. Deep brain stimulation. Deep brain stimulation surgery may be considered for patients who have severe symptoms, e.g., tremors, motor fluctuations, dyskinesias, and who are suitable candidates for surgery based on frailty, multicomplexity, patient preference. It involves electrical pulses being sent to the brain via surgically placed metal wires. These pulses help control the motor symptoms. It is the most commonly performed surgical treatment for Parkinson's. Source: Parkinson's UK. For an overview of the management of Parkinson's disease, read the following article. Non-pharmacologic management of Parkinson disease. Initial pharmacologic treatment of Parkinson disease. Version 2.10.6. Summary for management of Parkinsonism. Key learning points. You have completed this section. Review each key learning point before you progress. Symptoms of Parkinson's disease can be significantly ameliorated through medical treatment. However, there is no cure, and progression of the disease cannot be slowed. Dopamine replacement therapy is the mainstay of treatment for idiopathic Parkinson's disease, IPD. Other medications such as dopamine agonists and MAOB inhibitors are also used. Monitoring progression of the disease and the effect of pharmacological agents on progression is difficult with Parkinson's disease because its effect is idiosyncratic with a wide spectrum of symptoms, long time course, and lack of definitive markers. Deep brain stimulation involves electrical pulses being sent to the brain via surgically placed metal wires. These pulses help control the motor symptoms. It is the most commonly performed surgical treatment for Parkinson's. Deep brain stimulation surgery may be considered for patients who have severe symptoms, e.g., tremors, motor fluctuations, dyskinesias, and who are otherwise suitable candidates for surgery. Drug-induced Parkinsonism is less likely to respond to dopamine therapy than IDP. The mainstay of therapy for drug-induced Parkinsonism is slow weaning of the dopamine antagonist if possible. Version 2.10.6. Preventing deterioration. Jacob, 91, makes a visit to the geriatric medicine outpatient clinic. Select each tab to review Jacob's patient record. Patient. Presenting complaint. Medical history. Current medication. Patient. Name, Jacob. Age, 91. Jacob. Presenting complaint. Jacob reports new onset visual hallucinations over the past month. He sees small animals in his home and has insight that these are hallucinations. The hallucinations are not distressing. He has no paranoid ideas, delusions, or auditory hallucinations. Medical history. Idiopathic Parkinson's disease. History of falls. Constipation. Gout. Postural hypotension. Current medication. Cinemet 25/100 mg 4 times per day. What do you think is the diagnosis for Jacob? Show diagnosis. Given that Jacob has a prior diagnosis of idiopathic Parkinson's disease, the most likely diagnosis based on his new symptoms is deterioration of his existing Parkinsonism. He has new onset hallucinations, worsening constipation affecting appetite, and flare-up of gout. His medication is no longer controlling his symptoms as effectively. Patients with Parkinson's disease can often deteriorate significantly following a systemic infection. In severe cases, they may even develop an akinetic crisis. The underlying mechanisms behind this deterioration is not fully understood. Most common causes of deterioration: constipation, pain, infection, dehydration, malnutrition, acute illness, e.g., myocardial infarction. New medications such as dopamine antagonist. It is thought deterioration may occur due to changes in the pharmacodynamics of the dopaminergic drugs, altered dopamine metabolism in the brain, alterations in the dopaminergic transmission in the striatum, enhancement of neurodegeneration due to remote effects of peripheral inflammatory processes or circulating bacterial toxins. Source: Brugger et al., Gerlach et al. Select the heading to learn about the experience of deterioration for the patient. Experience of deterioration. Someone with advanced Parkinson's may experience the following: drug treatments that are no longer as effective, complicated drugs regime, less control of their Parkinson's symptoms, which become less predictable, more off periods and dyskinesia, increased mobility problems and falls, problems with swallowing, mental health symptoms such as depression, anxiety, hallucinations and delusions, and dementia. Many people with advanced Parkinson's will experience pain. Management of pain is crucial at this stage, particularly if the person has reduced mobility. Source: Parkinson's UK. People with Parkinson's most often die because of an infection or another condition. How do you think Jacob's condition should be managed? Show management. The appropriate treatment for Jacob is constipation management, adequate nutrition and hydration, treatment of pain. Version 2.10.6.
بكرة خميس.
Multidisciplinary care. Robert was followed up by the interprofessional team responsible for his care in the movement disorder clinic. He received physiotherapy for gait and balance training to reduce his risk of falls. This, in addition to levodopa therapy, improved his symptoms. There are a number of healthcare professionals, HCPs, that may be involved in the multidisciplinary team taking care of a patient with Parkinsonism. Select each HCP to learn more about their role. GP, neurologist, physical therapist, speech and language therapist, occupational therapist, mental health specialist, psychiatrist/psychologist, dietitian, social worker, nurse, gastroenterologist. Source: Hopkins Medicine, Goldman. GP speaking with elderly patient. In cases of acute deterioration, the GP is often the first HCP consulted by the patient. Systemic causes for motor or non-motor deterioration should be excluded, including medication, particularly in cases of polypharmacy. Levodopa is not usually a cause of delirium. Patients may find hospital admissions lengthy and distressing and wish to avoid them if possible. GPs should seek support from outreach specialist, neurology, geriatric, or palliative services to consider alternatives. Source: Williams et al. Late-stage Parkinson's disease, LSPD. Late-stage Parkinson's disease, LSPD, is a syndrome of frequent falls, cognitive impairment, and visual hallucinations. Patients with LSPD commonly experience episodes of acute clinical deterioration. While many symptoms remain levodopa responsive at this stage, some symptoms become levodopa unresponsive, particularly non-motor symptoms. Select each tab to learn more about acute deterioration in LSPD. Delirium. Pain. Motor deterioration. Falls. Delirium. Dementia is common in late-stage Parkinson's disease, affecting 83% of those with a 20-year diagnosis. This is characterized by day-to-day fluctuations in cognition, confusion, attention, and alertness, which emerges gradually. There is a higher risk of delirium in late-stage patients, particularly those with Parkinson's disease dementia, PDD. Delirium should be considered where there is an acute change in consciousness, attention, or cognition, or where there is perceptual disturbance. Tactile and auditory hallucinations are common and may be emotionally upsetting. This can help distinguish delirium from the chronic visual hallucinations and illusions of PDD. Delirium in Parkinson's disease is usually caused by one or more of the following: constipation, polypharmacy, infection, pain. Pain can predict acute behavioral or motor change in late-stage patients. Causes of the pain should be sought promptly, including multifactorial, systemic, musculoskeletal, neuropathic or radicular causes, as cause dictates treatment. Patients with late-stage Parkinson's disease, LSPD, are often sensitive to analgesics. Once such causes are excluded, consideration can be given to dystonia, akathisia, akinesia, and/or central Parkinsonian pain. Cause of pain. Treatment: adhesive capsulitis, targeted physiotherapy, radiculopathy, root injection, coat hanger headache, and neck and shoulder pain of orthostatic hypotension, targeted non-pharmacological and pharmacological treatment of orthostatic hypotension, constipation-related abdominal discomfort, high-fiber diet, increased water intake, laxatives, dystonia, akathisia, akinesia, central Parkinsonian pain, levodopa. Dopaminergic stimulation is vital for clearly dystonic or akinetic pain, and may alleviate the nocturnal discomfort of restless leg syndrome. Motor deterioration. Patients in later stage may become wheelchair-bound due to severe motor symptoms such as acute akinesia. While most motor symptoms remain levodopa responsive into later stage, the peak benefit gradually declines. Increasing medications to achieve the same benefit can lead to severe side effects. If the patient deteriorates with acute akinesia or rigidity, causes other than Parkinsonism must first be excluded. These include stroke, subdural hemorrhage, spinal cord compression, medication error, infection, and delirium. In patients who have undergone deep brain stimulation, DBS, the implantable pulse generator, IPG, should be interrogated to ensure it is still on and has an adequate battery level. Acute akinesia and rigidity may also be the result of Parkinsonism, hyperpyrexia syndrome, or serotonin syndrome. Hypophonia and dysphagia are motor symptoms and are usually levodopa responsive. Acute deterioration can occur if medication is inadvertently missed or withheld due to impaired swallowing. This can lead to a vicious cycle of worsening dysphagia. Use of dispersible tablets, crushed tablets, patches, or nasogastric tube may be warranted in some cases with a view to restoring regular oral intake. Falls. Falls are common in LSPD, but are often underreported because of a fear patients may have of having to enter residential care. There are a number of reasons for falls. Freezing of gait, fog. This is one of the most common and most unrecognized reason for falls. It is a brief absence of forward progression of the feet despite the intention to walk. Patients typically fall forwards on initiation or turning. This type of fall can occur when the patient is in a tight space or opening a door. Orthostatic hypotension. Patients with this condition may suffer a fall within minutes after standing. Some patients experience preemptive signs such as lightheadedness, visual dulling, diaphoresis, global weakness, or coat hanger distribution pain. Attentional fluctuation. Impaired attention predicts falling in Parkinson's disease as it affects postural sway and balance. Research has shown reduced power of attention and increased reaction time variability are associated with increased fall frequency. Source: Alcock et al. Comorbid causes. These include neuropathy, myopathy, and pain, e.g., arthralgia, radiculopathy, and spinal or vascular claudication. Source: Williams et al. How do you think Robert's risk of acute deterioration could be reduced? Show feedback. Robert should be educated on strategies to avoid causes of deterioration of Parkinson's such as constipation, pain, infection, dehydration, and malnutrition. For more information on deterioration in Parkinsonism, read the following article. An approach to acute clinical deterioration in patients with late-stage Parkinson's disease. Supplementary reading. If you would like more information on multidisciplinary care of a patient with Parkinsonism, consider reading these articles. What to look for in a Parkinson's care team. If you would like more information on diet, nutrition, and medication in Parkinsonism, consider reading this article. Diet and Nutrition, Parkinson's Disease. Version 2.10.6. Summary for preventing deterioration. Key learning points. You have completed this section. Review each key learning point before you progress. Patients with Parkinson's disease can often deteriorate significantly following a systemic infection. In severe cases, they may even develop an akinetic crisis. The underlying mechanisms behind this deterioration are not fully understood. The most common causes of acute deterioration are constipation, pain, infection, dehydration, malnutrition, acute illness, e.g., myocardial infarction, new medications such as dopamine antagonist. Healthcare professionals involved in a multidisciplinary care team for PD sufferers may include GP, neurologist, geriatrician, physiotherapist, speech and language therapist, occupational therapist, mental health specialist, neuropsychologist, dietitian, social worker, nurse. In cases of acute deterioration, systemic causes for motor or non-motor deterioration should be excluded, including medication, particularly in cases of polypharmacy. Late-stage Parkinson's disease, LSPD, is a syndrome of frequent falls, cognitive impairment, and visual hallucinations. Patients with LSPD commonly experience episodes of acute clinical deterioration. Version 2.10.6